Hello, my name is Nickhill Bhakta, and I'm a pediatric oncologist at St. Jude Children's Research Hospital, and I also direct our Sub-Saharan African Regional Program. It is my great pleasure to be here today to present on our St. Jude Global Program, as well as our Sub-Saharan African Regional Program. And I want to take a moment to thank Dr. Renner in particular, but the SIOP Africa team in general for the opportunity to present at this meeting. I know that I'm following Dr. Sharon, so I suspect that the issue of the global burden of childhood cancer has already been reviewed. We know that globally over 400,000 children develop cancer, but only about half of those are actually diagnosed. Those numbers, of course, are even more sobering when we look at sub-Saharan Africa. So faced with this reality, that does mean that potentially up to 13 million children, if we don't do anything and address this major deficit, will die from their disease as a result of their cancer, and that up to 6 million of those children will go undiagnosed. So how do we begin to address this, and what are the mechanisms that we can implement to really make a dent at this at a global level, but also in the region where the highest burden and where 25% of the children live, which is in Africa? And so from a St. Jude perspective, we see ourselves as implementers. We think of ourselves as putting together programs and allowing for our partners to really identify where their gaps are, where they want to prioritize and focus, and we can work with them to make those decisions, and then ultimately work to implement new programs and tools to hopefully address those gaps that we saw. And while that's a general philosophy, how can we actually operationalize that? And so I show on this slide what I consider to be kind of the standard from a patient perspective journey that one goes through. So a child, and this is something that every healthcare provider on this call probably can really relate to, and of course any survivor or advocate as well. First, the child has to be found. That means that we have to have a good case finding and referral mechanisms in place so that the child can actually be correctly diagnosed and referred into the treatment center where they may be able to get access to quality care. But even once they get to that treatment center, they have to actually get a diagnosis. So just recognizing cancer is the first step, or suspecting cancer is the first step, but getting the right diagnosis. And we know that many children are misdiagnosed. And we have data from the region showing that in some locations, retrospective analyses have shown that up to 30% of children got the incorrect diagnosis, and as a result, probably got incorrect treatment. Once we know what the right diagnosis is, we need to ensure that those children get the right treatment relative to the actual resources available. So we need to have resource-adapted management guidance. And then, of course, once we have those guidelines in place, we have to have access to the medicines and all the tools to actually provide that care. And then finally, we need to have the tools in order to be able to provide the quality and monitor for the quality of that care. And for us at St. Jude, we think of this as something called a value chain. And this is something we take from the business literature as well, that each of these components feed into the greater good. And if we only address one of them, we don't address the totality of the problem and ultimately don't make the impact that we're looking at. So we had to think about this holistically along each element. And so you've already heard about the WHO Global Initiative for Childhood Cancer and the cure-all package. So I'm not going to repeat that. But at St. Jude Global, we are really excited and proud to be the WHO Collaborating Center since 2018. And in this particular center, we have several terms of reference to support national cancer control planning efforts, to provide help and support with cancer management, research and education, and of course, provide technical support, training materials, stakeholder engagement in a variety of different ways, whether it be through costing analyses or whether it be through information or educational programs, or if it's about convening individuals within a country in order to make priority decisions. From a diagnosis standpoint, this is actually a relatively new program. It's something called the DIVIA platform, or Diagnostic Innovations for Value-Based Implementation Programs to Improve Access. And so DIVIA is a relatively straightforward concept. This is a reality that many of you, I'm sure, can relate to. A child comes into your clinic or into your hospital. They show all the signs and symptoms of having leukemia. You look at morphology from the peripheral blood and you see you see small round blue cells. But you're obviously left at that point with several diagnostic challenges. Is this AML or ALL? Is there a lymphoma subtype that you need to be worried about? Or could this even be other small round blue cells, rhabdomyosarcoma, and neuroblastoma with circulating blasts? And in places like at St. Jude, we have access to immunohistochemistry to further illuminate this, and not everyone has access to flow cytometry as well. And so therefore, you're left really wondering AML versus ALL. And then, of course, for risk stratification in the US, Europe, Australia, New Zealand, there's access, and even in South Africa and elsewhere, there's access to macrogenetic data. So you can get access to cytogenetics in fish, molecular diagnostics, all to get lineage and genomic subtyping. And so while we think about this in the middle income countries as being readily available, so again, Egypt, Morocco, South Africa, in many parts of the continent, we know that all you have is your morphology and alone. And so one of the questions we ask is we're sitting in the middle of a genomic revolution at this moment in time. So are we going to sit here and think about, okay, we're just going to build up all the capacity historically, or are we going to try to figure out, can we develop cost-effective, cost-beneficial tools that leverage diagnostics and allow us to leapfrog some of the traditional pathology, which would take 40 years and still don't have in place? And can we do this with an equity approach that allows us to think about the access to care that we have in our settings? And so what Divya is really a model whereby how can we know that with HIV or even with COVID, many of your labs around the world are actually conducting genomic sequencing. At least it's available in country. So can we perform that genomic sequencing for cancer diagnostics in a very cost-effective way as compared to flow cytometry or cytogenetics? And then ultimately leverage bioinformatics in a cloud-based environment so that we can return results to clinical pathologists to make rapid decisions and hopefully return those results back to the clinicians making the deciding. But also address another major equity issue, which is we know that, and we talk about it constantly, that 90% of the data in global genomic databases are from Northern white European populations. And the people of color continue to have a diminishing number of cases of genomics in those databases. So while we talk and lament about that, why don't we actually start to address that? And one of the ways that we can address that is by making genomic sequencing actionable and clinically relevant, not only just for research. And if we move in that direction, we can actually address that by increasing the amount of data in those databases and allow for secondary research. So that is really the premise of what we want to achieve with Divium. And over the next few years, you will hopefully see this being rolled out and become an opportunity for many of you to participate. But of course, once you have the right diagnosis, you still need to be able to manage that patient in your context. And so hopefully many of you are aware of ARIA Guide and the ARIA Guidelines Initiative. And the concept for this is we need to think about how do we develop standardized guidelines. And many of us think that our contexts are unique and we have to develop that at the hospital country level. But in reality, there's only so many differences in context when you're thinking about how to deliver general treatment for childhood cancer. And while there could be specific operational differences in a hospital, the general concepts of what to deliver in terms of care can be developed at a global level with stratification for access to resources. So how do you treat a child with cancer when you don't have access to radiation, or when you don't have access to CT scan? Those are things that are generalizable to many settings, not necessarily only unique to one. And of course, if anybody who's sat on a guidelines effort knows that takes a lot of effort to develop guidelines. So rather than trying to develop them in every country, let's develop at a global level and then adopt at the regional and country level. And then spend more of our time thinking about studying how to implement those more effectively. And this reduces time and allows us to take advantage of natural innovation labs to learn more about how to more effectively treat children in all of our contexts. And so ARIA Guide, aria.stjude.org or ariaguide.org, is a website that provides and disseminates this information. And I encourage all of you to visit and, of course, help participate, because we are all not only looking for experts in clinical trials and who are world leaders in their tumor types, we are also looking for experts in context, meaning you know how to treat children in your setting best. That's equally relevant and important evidence when we're developing these guidelines. So we invite you to participate. And then, of course, medicines. We know that medicines are essential in order to provide, but that stockouts that prevent us from being able to provide optimal care. And so together with the WHO and UNICEF, St. Jude is proud to really announce and be working towards the global platform for access for childhood cancer medicines. We have 6 pilot countries, of which Zambia is the representing in the Afro region. And within this platform, that we have made a commitment of $200 million over the next 5 years to treat 120,000 children with essentially what is a global fund for childhood cancer drugs. And then, of course, we know that there are many issues with quality assurance, affordability, availability, and in each of these domains, we are working with government as well as our partners on the ground, foundations, to make sure that these drugs are both reliable, quality, reduce costs through pool purchasing, and ensure that we have a rapid response mechanism to make them available. And then finally, what we really have to think about, how can we provide that quality of care? And so we have hospital-based cancer registries developed, profile tools, which I'll talk about in a moment, and other implementation and quality improvement programs, all delivered through the St. Jude Global Alliance. And so what is the St. Jude Global Alliance that I speak of? This is really a partnership that has evolved out of some of the early work that we did in St. Jude Global. So we've been working in this global space for over 30 years now, as an institution, starting in Central and South America as fellows that were trained at St. Jude, went back to their home countries, but then expanding to the Middle East, Asia, and Mexico. And by 2015, we, as an institution, were working with 24 programs in 17 countries. But of course, you can see that there's a glaring gap in that no hospitals in Sub-Saharan Africa were working with St. Jude in 2015. And for an institution that prides itself on a mission that no child should die at the dawn of life, we were only having a global reach of about 2.5%. So recognizing that that was insufficient for making an impact, our leadership really launched the St. Jude Global Program, and through that we launched the Global Alliance, such that from that 24 program, we've been growing steadily from 2018, 2021 until today. Now the Alliance incorporates 319 institutions, of which 62 are foundations, and we work in 84 countries. And what the Alliance allows is essentially an MOU between St. Jude and partner programs all around the world, with the understanding that it's a no obligation MOU that says, I care about childhood cancer, you care about childhood cancer, let's work together. And then from that, we can rapidly implement programs because we have a structured MOU that we can then put amendments. So if you're interested in having a program on reducing pain during procedural sedation, we can rapidly put into place the legal agreements in order to support with additional resources. Or if you're interested in implementation of early warning scores in order to prevent clinical deterioration, or a hospital-based cancer registry. We can put in the data use agreements, we can put in any funding riders that might need to happen, so that they can this helps expedite the process and also organize us so that we don't have only Africa working with Africa, but the problem that's facing Zimbabwe today may be the same problem that's facing the Kyrgyz Republic. So let's start to solve for that problem together as a global community, rather than necessarily only a limited number of group of institutions. So this allows for a networked collaboration and also fosters partnerships between institutions, not even outside of the St. Jude relationship. And then, of course, registry. I mentioned that we have to have quality improvement programs. We have the hospital-based cancer registry. We have now over 40 sites that are participating in our cloud-based version. We've also developed a red cap version where there's 25 hospitals in Brazil that are already participating in that. There's 5 sites in Ethiopia. And of course, INFOG in India is also adopting. So many regions, many countries are starting to adopt these standards that we've developed as a registry. For our cloud-based version, over 10,500 patients are enrolled. And of course, this is an open platform for any member of the Global Alliance, and is built on an equitable data sharing agreement. That's why we're able to enroll. That's why so many have enjoyed engaging with us, and also know that they own their own data, and also that they get quarterly reports with that information that they can do with as they please. So how have we started working in the region? How has St. Jude Global really focused and tailored our approach in Sub-Saharan Africa as opposed to other regions? And really, it's for us, it's 5 main principles. So we really engage in ethical components. So most of us have been colored by the HIV pandemic and recognize that, especially in Sub-Saharan Africa, you had a neo-colonialization in healthcare that occurred during HIV, with carving out of healthcare systems that did not necessarily follow the primary care or the public health systems. And usually that carving was done by high-income countries such as United States or European organizations. And while a significant good was done for programs like PEPFAR or others, the reality is that they left 2-tier systems or siloed or vertical programs that were not integrated. And so we, as a St. Jude Global program, work hard to avoid that. And we always want to work only where we're invited, So really respecting that we're not going to impose on anyone. And then, of course, eliminate duplication. There's too much work to be done. So if there are strong partnerships already in place, we want to foster those, whether it with high-income countries or between two different groups. We have no interest in drama or causing friction in those settings. We also work hard to engage all stakeholders at the local, regional, and international level. We know that there's a lot of good partnerships out there. Let's foster that together, and also potentially create opportunities for those partnerships to grow in the region as well. And then, of course, one of the areas of focus is that we want to support local teams to identify their own priorities. So that way, ultimately, whatever decisions to move forward with us at St. Jude Global is defined by the local team, not by St. Jude. And so what do? We talked about registries and ARIA. We also have the profile tool, which is our mechanism for really helping us to understand how to implement. The community today, it looks like this. There's over 28 institutions. Of those, 12 are already members and several more are in progress. This is an open invitation to anybody who's interested. This just shows the foundations that are also involved in our alliance. And I think that's important to highlight, that the alliance is a combination of both hospitals and foundations, because ultimately what we want to do is not only create implementation programs with the hospitals, but empower and train foundations to be able to more effectively fundraise, so that you are not beholden on US dollars or grant dollars, but ultimately those foundations can help fill in those gaps and sustain the programs until governments are able to commit the funds. And of course, how do we begin to then leverage that partnership? How do we bring teams together? It's really about how do we get to that goal of 85%, knowing that 20% survival right now? But the reality is that many programs don't know where they stand right now, and it's hard to set a goal. And so for that, we really have used our profile tool, which is it's an assessment tool of hospitals, but more importantly, it's about bringing stakeholders together, using the data from those assessment tools to make shared decisions. And when I say shared, I mean by the local team. So many of you have participated in these profile exercises, and they are an incredibly important tool that help us leverage all stakeholders to define a pathway for next steps in a local setting, because we can't do 20 different things at once. We have to make those hard choices and decide on a limited number of sets. And from that profile experience, this has allowed for many to leapfrog into the global GICC. So you can see this map of profile very neatly maps against GICC engagement, and that's intentional. We at St. Jude Global have leveraged our work with profile in order to help country teams, ministries, as well as implementing partners to pull together and then organize a request for the WHO to engage and help to provide technical advice in order to implement those priority programs that they've identified. And so with that, thank you so much for this opportunity to present, and I'll look forward to the discussion later.